recording. There's another person joining.
Okay, and let me just share screen.
All right. Well, listen, everybody. Thanks for joining. It's a pleasure today to have Joe Manjaly. He's a consultant otologist and auditory implant and ENT surgeon at the Royal National ENT Hospital in London. Um, Thank you, Joe, for taking the time out for the opportunity to get you to share your knowledge with us today. We have a group of people, as I stated before, from around the world, and we're going to record this lecture so that we can post it because I know a few people are having internet connectivity issues this morning. So let me not delay any further. We appreciate your time, and we're going to have a nice lecture today on single-sided deafness and hearing loss.
Super. Thanks, Richard. Yeah, thanks for having me on the series. So yeah, very grateful to be invited. And yeah, by all means, welcome any questions along the way. I'll just put the full screen on. So yeah, so a little bit about me. As Richard said, I work at the Royal National ENT Hospital in central London, and I'm an ENT consultant who purely specialises in ear and hearing problems for adults and children. So subspecialist otology work and also auditory implant surgery. So otology, I'm aware that I'll be speaking to some otologists and perhaps some rhinologists and laryngologists in the group, but we all know that otologic surgery involves delicate anatomy. Here we're down fracturing a stapes very close to a facial nerve. And I always, as I've gone through my career, it's become apparent to me that a patient's perspective on having ear surgery can very much depend on how it is described. And therefore, the threshold for offering intervention, I think, varies quite considerably within safe limits between different departments and different specialists. And if you think about it, in otology, it can be very easy to offer conservative management to patients in a way that perhaps people don't question. If you see a patient with an ear complaint, you meticulously clean their ears, you see them again, send them for a scan, see them again. That patient probably feels very cared for, very thoroughly investigated. And whereas you may not potentially have offered them all the options in terms of middle ear surgery if they've got a conductive hearing loss. And I think that it can be easy to just go for the non-surgical option and offer a hearing aid to someone. And if that patient doesn't want a hearing aid, then they may then feel that they have to accept their own difficulties, if they've been offered an option and they haven't taken it. And so I guess the point of this talk is that we as surgeons need to be able to explain the benefits of intervention just as thoroughly and just as well as we explain the risks. So we're all trained to explain the risks of surgery and warn people about the risk of losing hearing, of facial palsy, but are we as good at explaining the benefits? And I guess that's what this talk is about. So we know now that leaving hearing loss untreated has well understood consequences. In adults, we know that there's a link between hearing loss and cognitive decline with social isolation. And in children, we know that undetected hearing loss can lead to delayed language development, academic underperformance, social isolation, etc. But what about when someone has hearing loss in just one ear? Now, you'll find that people with a mild hearing loss in one ear can generally manage fine when they come to your consultation room. You won't really notice that they're struggling in any way. And even at home in a quiet environment, the same is true. And so it's very easy for others to think that single-sided deafness is not a big deal. And even within ENT circles, there's been this historic viewpoint of encouraging the patient to just rely on the other ear and make sure you look after it well and seek help if you ever notice any problems with your good ear. In a way that we would not do that for someone who has reduced vision in one eye if we knew that we could do something to reverse it. So I think that subspecialization is the way to be able to do more for patients safely. And I think that that's what we should aim for as a specialty, in a way that's equitable to patients regardless of geography. And I guess I wrote that with the UK in mind, but I guess it equally applies internationally as well. So coming back to, if someone comes with single-sided deafness, what are you going to explain to them are the benefits of reversing that? Well, first, so that's what we need to understand. What do you say, if someone comes and asks me, what are going to be the consequences of me losing hearing in one ear? What might you be able to help by reversing that? Spatial hearing is a big one. So I've got this video, I've put this video on Instagram. I won't play it now, but you're welcome to go and have a look at it, explaining this. But we're talking about one's ability to be able to detect which direction a sound is coming from without the visual stimulus. So think about when you've lost your phone in your house and you ring it to try and find it again. How can you tell which direction that ring is coming from without seeing the phone? Well, the answer is 3 things. Interoral timing. So a sound is going to hit one ear slightly quicker than it's going to hit the other ear. And your brain in that instant can process the difference to be able to tell where sound is coming from, in combination with interoral volume. So you need 2 symmetrical inputs for that brain processing to work in that way. The third thing being pinna shape. So the shape of your pinna can help you detect sound in your vertical plane. So people with microtia atresia have a reduced ability in that sense. And obviously we're relying on central auditory processing as well. Secondly, the head shadow effect. So related to spatial hearing, but not quite the same thing. So this is where someone might miss sounds completely from one side of their sound field. So, when you're talking about crossing the road, that can have a big safety impact. So think about the head shadow effect. Conversation in noisy environments. So again, with no background noise, patients with single-sided deafness generally can hear quite well. But once there becomes noise to separate speech from noise, that's where difficulties arise. Listening effort. So again, this is probably underappreciated even by ENT surgeons. Someone with a single-sided deafness will generally manage, but their brain will be working extra hard. And so we want to be thinking in terms of lightening one's listening effort and cognitive fatigue. Obviously, a lot of audio is broadcast in stereo and whatnot. And so one's appreciation of sound delivered in that way will be reduced if someone has single-sided deafness. And then you want to be thinking about plasticity. So we know that if an ear goes unstimulated for a number of years, the brain will use that part of the brain. That part of the brain will be used for other functions, which is why cochlear implantation, if a profoundly deaf child goes undetected and wants to consider cochlear implantation beyond the age of 5, they won't learn speech because they've lost those faculties. And it's the same with spatial hearing. If a child is born with single-sided deafness and goes unaided until about 7 or 8 years old, then even augmenting that sound at a later date won't get back those spatial hearing functions. So it's important to think about plasticity as well. So there we have it. When we're talking about risks of surgery, we want to also be thinking about the benefits. What's the potential benefit of me trying to intervene for a unilateral hearing loss? You want to be thinking about it in that sense. And I think as a specialty worldwide, we offer so many patients nasal surgery to unblock one nostril. Really what we should be doing is thinking about single-sided deafness. How much more should we be willing to intervene for single-sided deafness. And now, of course, nearly every patient has an option for hearing rehabilitation. And so the old mantra that it's either a hearing aid or struggle on is really not true anymore. And that's kind of what I'm going to cover next. So don't need to sort of talk you through how to interpret an audiogram, but essentially, you want to be seeing any air bone gap as potential for improvement through middle ear surgery. It's also worth throwing in there that sudden hearing loss is an emergency. This is, again, something I've sort of written with the UK audience in mind. I think, we see a lot of patients with sudden hearing loss that we could have given steroids to that don't make it to us in time. So I think picking that up early and referring in for oral or intratympanic steroids is an important message to keep sharing. But essentially, we should be examining ears under the microscope. Otoscopy at the best of times is difficult. And if there's an air bone gap on the audiogram, you want to be asking, well, how can I reverse it? So if there's a tympanic membrane perforation, can I close it? If there is ossicular erosion, can I do an ossiculoplasty? And if otoscopy is normal, then it's probably otosclerosis, and can stapes surgery be helpful? So, and a lot of this, most middle ear surgery can be done under local anaesthetic with sedation. So that also opens up possibilities in terms of facility for doing this sort of surgery. And my default is to do tympanoplasty, ossiculoplasty, and stapes under local anaesthetic with sedation for three main reasons: that it allows on-table feedback, so you can test hearing improvement on the table, particularly with stapes I'm thinking about. I think it reduces the complications because you get verbal feedback from the patient if they're feeling very dizzy as you're leaning on the stapes, and also quick recovery, so they can go home very quickly. So tympanoplasty for tympanic membrane perforations, and there are all sorts of ossiculoplasty prostheses for dealing with middle ears for which there's been ossicular erosion. Same with stapes surgery for otosclerosis. So if you see an air bone gap and a normal otoscopy, then think about otosclerosis until proven otherwise. A scan can be helpful, not necessarily absolutely mandatory. And again, this can be done under sedation. It has a 1 in 200 risk of a dead ear. That's the sort of risk rate I will quote for however well the surgery goes. So that's the balance that you need to talk through with a patient. And for many people, the chance to augment their natural hearing is worth that risk. And we shouldn't view restoring natural hearing as being the same as wearing a hearing aid, because they're two very different things. One is amplifying sound louder into an ear, and the other is restoring acoustic hearing. They're not the same. And so being able to explain that to patients is really important. If we can't close the air bone gap, either because it's not possible or we've tried, or there's no air bone gap and the hearing loss is purely sensory neural, then the next step to overcome single-sided deafness is a well-fitting air conduction hearing aid. Okay, and we should encourage, again, by explaining the benefits that I went through, you might encourage more people to take up this option. But of course, there are lots of reasons why people may not get along with an air conduction hearing aid: recurrent infections, stigma, being unable to wear one because of microtia atresia, problems with the occlusion effect, and feedback. So there are many reasons why people will give up on a hearing aid or not be suitable. And for those patients, you want to be thinking about implant options if that's available to you wherever you are. So, people often ask, when should you think about implants? Well, the answer is whenever a hearing aid isn't giving benefit or isn't tolerated. And there's a whole spectrum of implants available now. So, and that's what I'm going to go into. It's also worth noting that if you've got a very large air bone gap on the audiogram, you may get better amplification and better fidelity amplification from a bone conduction aid than from an overpowered air conduction aid. So that's worth bearing in mind. And obviously the decision to offer implant surgery is a multidisciplinary approach. It involves assessments from surgeons, audiologists, speech and language therapy. It may involve AVM, psychology, so on and so forth. And it is very much a team approach. So let's talk about bone conduction implants. So lots of people will have heard of a BAHA, but actually we want to be thinking about this as a bone conduction implant that is percutaneous. So think about it in that way, and then you'll always offer patients all the options, because there is also a magnetic solution called the bone bridge, which is an implant made by Medel, Austrian company. Essentially, they both work by taking sound and vibrating the bone directly, and utilizing bone conduction to mean that sound will be delivered directly to the inner ear. So however poorly the middle ear and outer ear is working, bone conduction bypasses all that. So a percutaneous bone conduction implant will protrude through the skin. That's the traditional BAHA that we know. It's now a quick operation. You can do bilateral surgery under local anesthetic in one operation. You don't need a CT scan. But for those that don't want metal showing through the skin, the bone bridge is a good option. It's slightly less powerful in terms of hearing losses that can be rehabilitated, but it's a good option for patients who have normal or only slightly reduced inner ear function and have an irretrievable middle ear. You do need a CT scan to check whether there's space to drill a well for it. And of course, with it being a bone conduction device, it can be used for single-sided deafness, and I'll come on to that shortly. Then there are active middle ear implants, which act by vibrating the ossicular chain. Now, there were two, but one has been discontinued. So we currently have the Medel Vibrant Sound Bridge as our option for middle ear implants. The indications are very similar to bone conduction implants, with the difference being that a middle ear implant will unilaterally stimulate, whereas a bone conduction implant will stimulate both ears to some degree. And this is what the sound bridge looks like. It looks quite like a cochlear implant in terms of the receiver portion. But at the end of this conductor link is a floating mass transducer that will clip onto the ossicular chain and vibrate it to augment sound. And there are lots of different couplers to mean that you can clip it onto whichever part of the ossicular chain is most appropriate. So the advantage being that if you provide unilateral stimulation, then that's going to be better in terms of spatial hearing, etc. This is how it's done: post-oral incision, drill a cortical mastoidectomy, and then identify the ossicular chain and clip it on. Now, these are the audiometric indications, but crucially, you need to have stable hearing. So you don't want to offer this solution to someone who's got progressive hearing loss, because if they then land up in cochlear implant territory, then this isn't going to be useful anymore, and you're going to need to subject them to another surgery. So it needs to be stable hearing, and the middle ear needs to be free of infection. So that naturally reduces the candidacy for this sort of surgery. And so therefore, it's generally a good option for patients with a non-functioning ear canal. That's generally the group that will find this useful. So patients with complete canal atresia or canal stenosis, or patients who have recurrent ear infections from wearing hearing aids. And then, of course, for when hearing becomes in the severe to profound category and the loudest acoustic amplification still doesn't give enough benefit, then that's where cochlear implantation comes in. And it's now day case surgery. It takes about an hour per side, and patients can go home the same day. In the UK, the criteria are such that in the public sector, one has to have hearing loss in both ears at 80 decibels or worse in 2 frequencies. But what about when hearing loss reaches profound levels in just one ear? In the public health service in the UK, we're not funded to provide cochlear implantation for single-sided deafness. And so you need to sort of evaluate what options are available to you in your particular geographical area. If cochlear implantation is not an option, then we start to figure out how can we send sound from the sound field of the profoundly deaf ear to the good ear. So that's what a cross-aid does. You'll have a microphone that sits in the ear without hearing, and it will transmit sound via Bluetooth to the good ear and put sound in at that side. So cross stands for contralateral routing of signal. Bone conduction implants work in the same way because bone conduction has a very low attenuation. So you can vibrate sound into one side of the skull and it will send sound over to the good ear. So that's how Baha and bone bridge work. And of course, it doesn't need to be a surgical solution. You can wear a bone conduction device on a soft band to give that a contralateral routing. So it doesn't need to, so think about this option for people that don't want surgery, and then they can take it off and on and use it in certain situations. But it's important to know what those options give and what they don't give, because remember, to have spatial hearing, you still need binaural input, and Baha and bone bridge and a soft band and a cross-aid won't give you that. So you need to be able to explain that to patients, that a cross-aid won't give you back spatial hearing. It will reduce the head shadow effect. So if your cross-aid or your Baha is picking up sound from this side of the head, you'll help the patient to stop missing sound from that side of their head, and so you are overcoming the head shadow effect. The impact on speech in noise is variable. It sort of depends on where the speech and where the noise are in the sound field. It will help with listening effort. Again, improvement in music appreciation is limited. It sort of depends on the method, on the way the music is being delivered. And it's not going to have an impact on plasticity if you're not actually inputting sound into the ear where hearing has been lost. But there is one emerging option for true restoration of binaural hearing, and that is cochlear implantation for single-sided deafness. And it's not funded in the UK in the public sector, but it is available privately. It's really a cost effectiveness issue rather than an effectiveness issue. There's emerging evidence now that cochlear implantation for single-sided deafness can restore spatial hearing functions. And so in some ways that would be the treatment of choice for unilateral profound deafness. Great, I'll stop there. Happy to answer any questions. These are a couple of books that I've published, which are really geared at UK trainees, but do have some useful insights for any ENT surgeon in training. Yeah, happy to answer any questions.
Joe, why don't you mention also some of the other benefits of cochlear implantation for single-sided deafness? Like, noise reduction. Maybe can you answer a few of those questions for the audience?
Yeah, so I haven't really touched on tinnitus, but of course we know that cochlear implantation can be very beneficial to tinnitus. But essentially, cochlear implantation for a profoundly deaf unilateral hearing loss is the only way of restoring a truly binaural input. And so by restoring binaural input, what you're aiming for is to restore all these 6 functions that I've listed there. And to what degree that will be successful really varies on individual patients. Obviously, you're relying on good central auditory processing to be able to assimilate an acoustic sound and an electrical sound. So someone who has lost their hearing for a very short period of time and is young is going to be able to do that much more quickly than an elderly patient in their 80s who has been profoundly deaf for 15, 20 years. But these are the things that we're trying to potentially ameliorate by performing cochlear implantation in a profoundly deaf ear.
Okay, and then what about somebody who is a candidate for unilateral cochlear implant because of single-sided deafness? What is there an option to preserving any of their residual hearing if they have a certain frequency range?
Yeah. So hearing, so take an audiogram like this, where someone is in criteria for cochlear implantation. They're at the frequencies between 1 kilohertz onwards. The hearing loss is profound, but in the low frequencies, they've got good function, which is obviously going to be helpful for spatial hearing and all those other functions, and also hearing when the implant is switched off. So we now know that we can preserve that hearing. It was previously thought that by instrumenting the inner ear, you will lose all natural acoustic hearing. And for some patients, that's still true, but we know that there are things we can do to give the best chance of preserving hearing in the short term and potentially in the medium term as well. What we don't know is what things truly modulate that success of acoustic hearing preservation. So good practice is performing the surgery in a soft fashion, i.e. lowering the drill speed when opening up the round window niche, a slow insertion. Some people insert the electrode through steroid. It's also thought that different types of electrode are better or worse at preserving natural hearing. So our default where we work is a slim straight electrode. We think that has the softest the softest characteristics for inserting into a cochlear to try and reduce natural hearing. And then there's debate over whether inserting the electrode through the round window or through a cochleostomy has better outcomes for natural hearing preservation. But we should all be doing this sort of surgery in a way that gives the best chance of preserving natural hearing, because we know that there are benefits to doing that.
Great, thank you. Misha, anybody else have any questions? Jeremy, I see you joined us today, which is a nice thing. Any of you have any questions for Joe?
I'd just like to thank Joe. It's just great to hear his talk. And I also wondered if I could ask a question to the audience, because obviously we've got a very broad range of people signing in. It would be interesting to know how many people in the audience, from whichever countries they may come across, have come across any of the implant options that Joe is discussing, and the availability of things like bone conduction aids, and even cochlear implants. I know there are parts of the world where cochlear implants have been taken that are also very remote. It'd just be fascinating to hear from people what is accessible locally, and the routes of referrals. If someone has to send to the capital or send people internationally, it'd be just very interesting to know that. Feel free to put it in the chat or just speak.
That's a good question. Aziz lives in Somaliland. Aziz, if you would, could you share what options are available for patients in Somaliland?
Oh, sorry to hear that, but I'm in a noisy place. Can you hear me clearly?
Yeah, we can hear you good. Thank you, Aziz.
Yeah, thank you, Prof. Our option is at the lowest options in anybody in the world, and because we are in a third world and in Somaliland, the patients with the unilateral hearing loss or sometimes a little hearing loss, we just tell them we need to protect your other ear. But for the patients with profound cerebral hearing loss, there's no options here, and we don't have a program for cochlear implantation yet, but it's just a dream. So I am the one who is dreaming to do that in the future for my country and my people. And thank you for the good lecture, and also we are appreciating the lectures for GEO and for updating my otology lectures. And thanks, Prof, for that's all.
Okay, Aziz, thanks for your comments.
All the best.
Agata, you're sitting there in Poland. Tell us about what options there are in Poland, okay? Agata, you there? She's taking a break. What about ANS? I'm not sure who ANS is. If you're there, can you comment on your country?
Hi, this is Andre
Okay, Andre, hi.
in Trinidad and Tobago.
Oh, Trinidad Tobago. Okay, very good, Andre. Can you share with us, what options there are for patients in your country?
Well, we are kind of similar to what was mentioned for Somaliland, in that we don't have a cochlear implant program. Occasionally, we do get some done where surgeons who are originally from Trinidad may come down to Trinidad and perform one or two, maybe once per year, if that many. But other than that, we're doing similar thing where we tell patients to pick their better hearing aid and using the wearable devices.
Do some patients ever choose to go abroad for treatment? Is that?
At least in my experience, I've never had any patient who has done that, but the option sometimes is discussed with them if they can afford.
Great. Thank you, Andre, for your time. Artem is from Chernobyl, Ukraine. His father is a otologist, and Artem is
Hi.
inspiring otologist as well. Artem, can you tell us what options there are in Ukraine, let alone Chernobyl, for patients with single-sided deafness?
In Ukraine, it's only in 2 countries. There are only 2 towns that perform in cochlear implantations. Its capital, it's Kiev, and also another one town called Dnipro. This is about cochlear implantations. About Baha and other implants, I don't know. I know that in Kiev they perform in bone anchored Baha. What else? I don't know. I never said it. About our country, there are our government buy implants, and people need to stay in the queue. And people that have a lot of money can buy implants themselves. That's all.
Okay, well, listen, thank you, Artem, appreciate it. Damien, if you're there, would you comment on your experience? Damien?
Yeah. Hi, Dr. Wagner.
Hi, Damien. How are you today?
Hearing me?
Yes, we hear you fine, Damien.
I'm okay.
Could you comment on what options there are in your country for single-sided deafness?
Well, we have the surgical skills, but I don't know if it's an option for doing implants. We have a neuro-otologist, but I don't see that as a common surgical procedure in the public setting.
Okay, and could you tell everybody where you're from? Damien?
Yeah, yes, Dr. Wagner. Connection's breaking up.
Could you
I'm in Jamaica.
Tell everybody where you're from?
Jamaica.
Jamaica.
Oh, I'm
Okay, thank you, Damien. Thank you much. We're going to talk to Izzy from Ethiopia. Izzy, if you've got a good connection and you're available, could you comment on what goes on in Ethiopia?
Hello, everybody. Yeah, so I'm Isaac from Ethiopia. I mean, thanks to some of the programs with GEO and with the Chicago uh, health facilities, there is a cochlear implant that they're planning with the Otology Society here. But we have the numbers are really low, like only 6 or 7 cochlear implants have been done, but there are no options for the other devices, the Bahas. And yeah.
Okay, very good. Thank you, Izzy. And I hope things are getting better in Ethiopia with the civil war in the north. Um,
Yeah, yeah.
our
Things are
thoughts,
getting a lot better.
okay, our thoughts are going out to all of you there. Okay,
All right, thank you. Thank
you're
you.
welcome. Say hi to your father. We're gonna
Okay,
go.
I will.
Thank you, Izzy. Okay, we're gonna go to Paraguay now. Nestor, if you're there, Paraguay, we'd like to know exactly what kind of options are there, Nestor. So could you share that with us?
Yes, hello everybody. Hello, Dr. Joe. Hello, Richard. In the private system, health system, we got available all the options that Dr. Joe mentioned. I believe the only thing that we haven't done so much here is the middle ear implant, but bone anchored and cochlear implants are available for the private systems. For the public system, we got available cochlear implants, but the government only buys like 2 or 3 for per year. We haven't got a real hypoacusia program here. The government only buys sometimes when you got some friends at the government and you are able to work with them. But all the options that Dr. Joe mentions are available here.
Okay, great.
They are really expensive for people.
Mm-hmm.
Yeah, I'll have to admit, of all the countries, well, of all the Andean countries of South America, Peru, Bolivia, Paraguay, Ecuador, um, Paraguay has an otology training program, and their otology in Paraguay, for such a small country of like 7 million people, is by far as good as Colombia, Argentina, Brazil. Brazil's got 300 million. Okay. No, excuse me, 200 million people. Um, and Paraguay is like, they're on the map. They're really on the map. Peru and Bolivia, they're not on the map. Um, but Paraguay really holds their own when it comes to, you know, what is available and the training of physicians, and they even have a fellowship program in otology in Asuncion. So that's very good. Agata, go ahead. Go ahead, Joe.
No, Richard, it's just a comment. I mean, obviously, just from it's really insightful hearing those experiences from all over the world. And what's clear is that different options are available dependent on geography, finance, but as an ENT community, I guess that sort of reinforces the point of my talk, which is that we need to be able to explain the benefits and the limitations of every type of option. Yeah, I'd be intrigued actually to hear your experience. When you've obviously decided to go down the CI route. Was that explained to you? What a Baha would do and what it wouldn't do, what a CI would do, what it wouldn't do, what you would experience if you didn't have any option. I guess that's what I think. As a community, we could do better. But I'm interested to hear what your experience was like.
My personal experience is basically, obviously, my knowledge of otology, and I knew what my options were. So,
Sure.
Fortunately, I just got on a health insurance policy because of my age in the United States, and I would, I have this opportunity. I'm very surprised that my insurance approved it the first go ahead. Very surprised. Okay, I mean, we were ready to battle them, but it's happened, and we'll see. We'll see what next month has to bring for me in terms of I really need to get sound localization and the tinnitus under control.
Yeah.
We have Agata is on duty. She is on with us, but she did send a message saying that we have implant programs available. As a matter of fact, I'm fully aware that Poland, they do have in Warsaw, they got Kaczynski or some guy who's like, he's very big in implantation. He does go to Ukraine and captures patients to bring to Poland for his, for his work. I'm not sure what other options are available. I would assume that they do cochlear, they do bone anchored ear implants. I'm not sure if they do middle ear implants, but I can't answer that. I know in Italy and Spain, they're on par with all parameters of you know cochlear implants, bone anchored hearing aids, and middle ear implants. Garcia Baños in Barcelona, Giovanni Denisi in northern Italy, and Mario Sana. I mean, they're all doing them all. So it just depends on the economy of the country, the training of the doctors, and the availability of the financing system and the healthcare insurance. So, yeah. Anybody else have any questions? Jeremy, would you like to make a comment possibly, since you're active?
Can you hear me?
I should add before Jeremy speaks that everything I know about otology is learned from him. So
yeah, don't believe too much what Joe says. No, I do have knowledge of the Polish system in the Skaczynski Foundation, which is called the World Hearing Center. It's obviously got quite a grandiose ideas, but it's an incredibly impressive setup by Henryk Skaczynski and his son Peter, and they do all types of implants there, and it's an incredibly well organized center. And if you ever wanted to go and visit somewhere and just see how it can almost be industrialized implantation, then it's worth going to see them there. I'm not sure of other places. I did go for a cochlear implant meeting in Warsaw, but it seems to be fairly well penetrated in Poland. Mm-hmm. Beyond that, no, nothing more. Thanks, great lecture. Sorry I was a bit late. I was having to do my clinic, but good to catch the end of it, Joe.
Cheers.
Yeah, the Polish people seem to capture a lot of things east of Poland. Okay, east and southeast and northeast. Latvia, they have a big market. Okay.
I mean, it's amazing. They just purchased some land and built this center. It's just utterly astounding for us who work in London, thinking our hospitals have to be so reduced in size because of the footprint. But this place is amazing.
Thank you for your comments. Well, Joe, listen, I don't have any more questions, and unless somebody else does, I really want to thank you for the opportunity of sharing your knowledge and the comments of everybody who's made comments today. We'll post this on the global YouTube website. Misha will handle that, and we'll look forward to sharing this talk with other people who dial into the channel. Okay.
Thanks very much. Thanks, Richard and Misha, for inviting me on. Real pleasure.
Okay. Thank you, Joe. Thank you, everybody, for joining.
Cheers, guys.
Thanks
Good
so
night.
much.
Thanks, Jeremy. Bye-bye.